I want to start with the title of a paper, editorial paper, of Professor Trump. Let's say, pathogenesis of multiple sclerosis. The eye only sees what the mind is prepared to comprehend. This is perfect for our talk. We talk about multiple sclerosis, and these are the main characteristics of multiple sclerosis. The most common chronic disability disease of the central nervous system in young adults. We think that in worldwide there are more than 2 million of people affected by multiple sclerosis. And the age of onset of multiple sclerosis is usually is between the third and fourth decade of life, where every people plan the future, the personal future and professional decision. And this is a strange disease because everything is variable. This disease can hurt you in every time. Often when you are in a period of stress and after delivery. And the relapse, what we call relapse, are neurological deficits that affect the patient with a slowly progression in 1-2 days. There is a steady state, and then there is a phase of recovery after steroid or also without steroid. And this is what we call the relapse-remitting form. But most patients, after many years, have a progressive form. This form are very terrific because there is no treatment at all, no drug treatment really effective in this patient. But what we know is that after 10 years, many patients lose the work, the job. And 50% of the patients after 25 years are unable to walk. In Italy and in the United States, we are in a high prevalence of disease and incidence, as you can see in this cartoon. But the main characteristic of multiple sclerosis is these 3 points. Evidence of dissemination of lesion in space, multifocality, evidence of dissemination in time, relapses or progression, slowly progression. No better explanation. What does it mean? It means that until now we have no test that can say with absolutely certain that this patient have MS, like in diabetes, do glycemia and you say, yeah, you have diabetes. Multifocality means that the dispersion in the brain of a lesion. You see indicated by the arrow, the plaque of demyelination. And as we saw, we will see later, every plaque are around a venous vessel. And there's dissemination in time. This is very characteristic for all forms. You see relapse and remitting form, the scale. Do you have a pointer? Oh, here. Yeah, you can see relapse and remitting form where there is a sort of deficit, neurological deficit, and the return to the previous situation and a second relapse. This is typical for relapse in remitting form, but sometimes there is a permanent deficit after one relapse. The second form is primary progressive, where the disease has no relapse. The disease starts usually in the lower limbs and progress with the motor and sensory deficit and to the upper limbs in many years. There is slowly loss of function. Secondary progressive form are the most frequent for me, and there is the first phase of relapse and then the slow progression. Those are the main clinical features. We can see visual and afferent and efferent deficit, motor deficit, sensory deficit, deficit in coordination, urinary and bowel dysfunction, and cortical involvement. That means a sort of cognitive dysfunction. And MS is a heterogeneous clinical. In MS we put together many syndromes. You see severity and chronicity in XY axis, and you see the form called the fulminant, ADA-EM. That means there is only one relapse in the life. Or Marburg is a real devastating disease and many patients die, but it's very rare. And you see isolated form where there is only one area affected, that may be the optic nerve or prosthetic or myelopathy. There is also benign form that are after 15 years. There is a very few deficits. And there are progressive form that may involve the spinal cord and the cerebral system. No other explanation for diagnosis of MS. This is very important because we have no marker of disease. Well, 4 years ago, we decided to start an active collaboration between our two centers. I'm living in Bologna and working in Bologna, and I am the chief of the Center in Bene, Centro in Bene, that is a center for rare neurological disease and neuroimmune disease. And we met Paulo Zamboni, who is the chief of the Vascular Disease Center in Ferrara, and we fall in love. Because what he said were really new. I was looking for something new because many things were not compatible with an autoimmune disorder. So I had a lot of things about him, and I decided, me and Ilaria, to start this collaboration, this fantastic collaboration. And we started, I think, the first venous neurovascular team, where I learned a lot of things about veins. Veins for the neurology are nothing, are a tube. But now I open my mind, I see a lot of diseases that may have a venous pathogenesis. And Paulo learned about a lot of things about neurology. So it was a sort of master. Okay, this was the first paper of this collaboration, published in 2009. And Paulo called this entity chronic cerebrospinal venous insufficiency. It's a new disease, I think. It's a new, with a new etiology, and with a we will see. what was terrific was that all my patients, all patients that Paulo studied, belong to my MS center in Bologna. All patients that Paulo studied had 2 out of 5 Doppler criteria for CCSVI. All. This is terrible, because in medicine you may never say all, but this is what I found, what Paulo found in my population. But if you go to the literature, the prevalence of CCSVI in MS population is too much variable in different MS centers. And I think that this may be due to these 4 points. Different training plus personal learning curve of ultrasound technician, this is very important. And it's very important to have a technician and a doctor collect. No rigid application of Zamboni's criteria, short time devoted to the detection of CCSVI. There is one center in Italy that do the examination in 15 minutes. This is ugly. I know that they don't see anything because they don't want to see anything. In 15 minutes, it's nothing. And the last one is different setting ultrasound machine. And what we learn is the type and location of venous malformation in a large population of MS patient. You see amelia septum, hypoplasia, twisted membranous obstruction, and genesis. And the vessel involved, azygos, distal azygos, lumbar, jugular, and so on. But Paulo did a good job, and he found 4 hemodynamic patterns, A, B, C, D, according to the vessel involved. And I want to point the type D, that is all the azygos system affected in various segments. And we will see later, pattern D is very important for some progressive MS. Okay. And when Paulo did this classification, we went back to the clinic and we tried to correlate clinical cause and hemodynamic pattern, because this was very important for us to try to correlate morphology, hemodynamics, and clinical and neurological clinic. And we found these very important things. Type D was present in almost all patients with primary progressive form. And the type of malformation was agenesia of the lumbar plexus. It was really impressive. No vessel. The flow inverted from the up to down to up of the spinal cord. And this was very, very important. So the first correlation between vascular malformation and clinical. And when you see relapse in remitting form, most of the half of the relapse in remitting form belong to type B. So in summary, relapse in remitting form have much more alteration in jugular vein and primary progressive in the lumbar venous system. Okay, we try to correlate MS onset, and we have the same important result. Spinal cord onset were present in almost all have type B, and optic neurites belong to type A. Yeah, and we did also treatment, and we published the endovascular treatment in a paper in a good paper. in the journal. And this was the population reported. It's important to say that we never change MS therapy treatment in all patients. So in order to have another bias, we keep the treatment still. And we studied 35 MS patients in the first study, 20 secondary progressive patients, and 10 primary progressive patients. And this was the items: relapse rate, ESS, MRI outcome measure, disease severity and quality of life. And very short, because these data are just published, we found that the percent of patients that relapse rate were 27 1 year before treatment, and they were 50% after the patient 1 year and a half after follow-up. Can you see? Yeah? Yeah. And if you go to EDSS, annual relapse rate, you see that there is a sort of fall in relapse rate after treatment. We pass from 0.6 to 0.38. And same for EDSS. EDS2, 1 year before treatment. This work is related to 44 patients with relapse-remitting form. Only partly were described in the previous paper. EDSS, 1 year before 2, and 4 to 1.5 after 1 year. And this is very important. All relapses were associated with the restenosis of one or more veins. This was true for jugular vein, but not for azygos vein. You see this azygos vein treated, the twisted of the azygos vein, and after liberation, you see very, very little congestion after treatment of the vessel. And this is an example of pre-liberation, post-liberation, and restenosis in the lower row. The reason of restenosis, it may be, these are absolute hypotheses, inefficient dilatation, persistence of the valve, venous valve, partial or complete thrombosis, exuberant scar tissue. But this is very important to keep in mind. All our patients with post-procedural patency of the jugular vein and azygos vein were always relapse-free. We have a follow-up of 3 years. So it is mandatory to try to restore a normal venous outflow from brain and spinal cord. But this is very important to know. Not all patients have a treatable form of venous malformation. A patient with primary progressive form, with the genesia of the lumbar plexus, I think that will not benefit 100% from this treatment. So these cases require a new treatment strategy, and the door is open to future research. MRI outcome measure, we are only partial data, but the trend is very important. As for disease severity, quality of life, but what we found is what most of neurologists think, that this is a terrible procedure. We have death, we did a lot of catastrophic. It's not true. It is a safe. We have to say to everyone, it is safe. I personally follow this patient. It is a procedure safe. And the people that do this from 15 years say the same. Okay, say to your neurologist, it's safe. It's important. But what we say in this paper is this is not an open label randomized trial. So we need further randomized control study, and we are planning in the future 2 months. This is another wonderful part of the research, neurophysiology. One of our aim was to determine and to measure the modification after the liberation procedure. And this is one of the first patients we followed. And we broke another axiom. That means that neurophysiology can ameliorate in MS patient. And in this patient we saw, after liberation, they increased the motor potential. That is terrible. No one can believe it. No neurologist can believe it. And the shortening of the potential. This is really new in medicine, that a procedure can modify neurophysiology. And this is a very important portion. We talk about CCSVI. But is there a clinical pattern directly due to CCSVI? And this is it's a very important observation from a neurology field, because we followed up very strictly our patient, and we have 2 points suggesting that there is a clinical pattern related to CCSVI. So increased venous insufficiency in the brain and spinal cord, liberation procedure, and RIS, Radiological Isolated Syndrome. And we learn about from our patient after liberation procedure, because soon after the liberation procedure, the following symptoms changed: fatigue, headache, quality of sleep, and working memory, indicating a cause-effect linkage with the venous hemodynamic modification. So the first step is malformation congenital. We think that these malformations are congenital. Congenital malformation in veins, drain, CNS, central nervous system, the formation of a CCSVI, and those 4 are directly related to CCSVI. Fatigue, headache, quality of sleep, working memory. The first one, fatigue. No one knows, no neurologist knows why fatigue is due. Exactly the cause of fatigue. And no treatment at all is effective. Mantadine is not so much effective. And it's a very big problem. But this may really be due to CCSVI. You see, more than 40% are described fatigue as the most disabling symptoms, and 9% is from weakness, spasticity, motor problem, or bowel, or bladder problem. And we don't know nothing, but after liberation, fatigue decreased. And if we have a restenosis, the first symptoms that may happen is fatigue. This is very important. Headache. This is another very important and I think specific for MS. We know that the frequency of headache in MS population is higher than in our age population. It may accompany disease relapses. And another thing is that sometimes it worsens in supine position. And this is a sort of headache that is really atypical. But we know this. We know that most of the headache in MS patients are worsened in supine position. This is important because if you go to the hemodynamics, you can see that when the patient is in upright position, you see the vertebral venous plexus draining almost all of the blood in the brain. But when you go to the supine position, you see that most of the blood is draining from internal jugular veins. If you have a stenosis in the jugular veins, you may have a big problem where we are in supine position, like you stay almost 10 hours a day during sleep. Okay, quality of sleep. This may really be influenced by jugular obstruction. And a lot of patients with MS are poor sleepers. And we have much disorder related to sleep. But we know that, from the diary of one of MS patients, after liberation procedure, I can sleep better. I feel less tired in the morning, and so I have much energy and desire to do things. Moreover, I have begun to dream again, or at least I remember my dreams, like our dreams. And this is very important because this improvement of quality of sleep is sudden after liberation. The same night, in almost all patients, they sleep well. Working memory. Working memory is another important factor ameliorating after liberation procedure. And you see that patients have more attention, are really make less intellectual fatigue after the job. And this was in this cartoon you see before and after liberation. Superman. This is what we learned from after liberation. But there is another point that is very important. We have a patient with who did MRI for many reasons, and radiologist said, yeah, Dr. Salvi said, plaque, MS, but I feel good. What does it mean? What does it? There is a phase of the disease, what they call pre-MS, where you haven't the characteristic to have a diagnosis of MS, and you haven't the characteristic to have the diagnosis of CIS, that means clinical isolated syndrome. But you have only one MRI altered. So this is the condition where you do an MRI for some reason, and you say plaque. And this is a terrible thing, because you don't live no more, because you have in the mind, I may have MS, like in this cartoon. Radiologically isolated syndrome is a recent defined entity described as the incident discovery of lesions suggestive MS on brain MRI scan, demonstrating dissemination in space without symptoms, expression, and with a normal neurological examination. But this is not true. If you go to the reason for doing an MRI, you see headache, fatigue, quality of sleep altered. So this may be the expression risk of CCSVI. And you have neurological deficit. You have in almost of this patient you have evoked potential normal, and you haven't polyclonal bands. So the long travel of CCSVI to MS. Risk, that may be the real expression of CCSVI, CIS, the onset of MS, and you see relapse remitting, secondary progressive, or primary progressive, And this syndrome may be related to the location and type of obstruction in the venous vessel. Malformation, CCSVI, the formation of a plaque and normal appearing white matter. The plaque are always venocentric. This is what found the Sherlock Holmes. And I'll show you the plaque. Those are perimeter plaque. And you see the venous vessel, and if I do up and down, you see that all the plaques are venocentric. And this is the middle. Yeah. This is corpus callosum, and you see the vascularization of corpus callosum, and the lesion are also in this case perivenous. This is spinal cord, and you see the venous anatomical structure of the spinal cord, and you see a plaque resembling the venous area draining. But you see also in cortical lesion in MS that all the lesion, there are 7 types of different lesion, and the majority of this lesion are around the cortical veins. So this is another mistake that may be solved. What we found in advanced stage of disease, we found 2 more problems. The first one is iron storage in the parenchyma. The second, what does it do with the CSF, cerebrospinal fluid, when the venous, in presence of venous insufficiency in the brain? And we go on. Iron storage in the delineation plaque. This is a picture of Zamboni. This is the iron around the MS plaque. So it's not casuality, like many neurologists say. Degeneration. Oh.
Help.
So many neurologists said that the accumulation of iron in the brain is present in almost all neurodegenerative disease. I think that Dr. Rack is not in agreement with this hypothesis. So it doesn't matter. It is very few, and it is not clinically important. Okay. We know from the literature that this is not true. It is maybe present in also patient, and we will see more MRI corpus of markati, and you see the accumulation of iron in the purulent and in the basal ganglia. But I think it's not absolutely related to inflammation. And you see in the slide the accumulation of substantia nigra. And I saw extrapyramidal signs in an MS patient, as you see in this cartoon. It's very rare, but you can find, if you look for extrapyramidal sign, a Parkinsonian syndrome in patient with MS, no rust. You see my cartoon. And the other thing is what happened in the cerebrospinal fluid after when you have a CCSVI. You see the venous engorgement, and you see CSF with a high pressure, because the CSF draining into the vein. And we started with Professor Diodino in a project called 40,000 miles for therapy, and we see a lot of wonderful things regarding CSF relationship with MS. This is a neurological syndrome called the normotensive epicephalus, where there is a triad with a cognitive decline, gait is small step with a large base that resembles magnetic gait, and the urinary continence. This is normotensive epicephalus. This is my patient. And you see with the time, 2005, 2008, 2009, 2010, you see the lateral ventricle increase in size over the time with a normal, pretty normal cortical volume. So this is very important because we can do something in this patient. And when I talk with the neurologist too, they say, yeah, cognitive decline is part of MS. Gait is most step is a part of MS. Large base urinary continence is part of MS. Okay. But we can see, if we see together, they have a solution. Normotensive epicephalus. Okay, looking forward. What we are working now is the creation of a multidisciplinary team, like our team, in each MS center. The characteristic of MS center is to have a 360-degree mind open. Because we need a neurologist, an interventional radiologist, and a Doppler technician able to work together. It's not really simple. Research protocol, therapeutic multitasking, and the last one is a spy story in MS work, the new one. So, multidisciplinary team, and you see, those are three crazy men working together. Zamboni, Salvi, Galeotti.
Awesome.
Work in progress. And therapeutic multitasking. So, this is very important because we have many steps. We can find the malformation in brain and treat them. I don't know if it's correct or not. We may wait for a race, Radiology syndrome. When there is no deficit, neurological deficit, we can wait for CHIS when there is the first neurological event, or we can wait for MS, RR, PP, or SP. So the best thing to do is to confirm the result of liberation procedure. If the results are really good, we can go on to do this liberation procedure. But we have to keep in mind that there are other factors. Venous-centric inflammation. Inflammation has to be treated. So we never say interferon, copaxone are devil. Never. We never take off the drugs. And this is very important to keep in mind. Say to our neurologist, Dr. Salvi say that the disease, the drugs have to remain. The second is iron storage in the parenchyma. And